This is pulmonary part 2, and I need to get up to slide 21. It's certainly creative. Almost there. Pulmonary diagnostic procedures. Blood gases. Your PO2 is normally 80 to 100. This is your plasma oxygen. In infants, the normal is 40 to 70. If you're over 60 years old, you can take 80, the low normal number, and subtract 1 millimeter a year and still be normal. But please remember that any time your PaO2 is below 40, it is life-threatening at any age. So that is never, ever, ever normal. Your PaO2 will increase with supplemental oxygen. Your hyperventilation will occur with anxiety, hypoxia, blood clots, or pregnancy. If you have a healthy individual, you can take your FiO2, which if they're healthy, they're on room air, that's 21%, and you can multiply it by 5, and you should get your PaO2, which should be 100%, or 105. If your oxygen levels are decreased for 6 hours, you have hypoxia. Your decreased PaO2 will lead to lactic acidosis and metabolic acidosis. And there's a table on page 592 that lists causes for acid-base disorders. Your PaCO2, your normal is 35 to 45. If it's over 50, you're in respiratory failure. If it's less than 35, you have hyperventilation or compensation occurring. Your bicarb, normal 22 to 26. You can change your PaCO2 in minutes. Changing your bicarb takes hours to days. It will decrease with diarrhea, ketoacidosis, lactic acidosis, renal failure. It will increase with fluid loss from vomiting, suctioning, diuretics, a low potassium, administration of steroids, or antacids. So again, this will take hours to days to correct without assistance by the medical field. Your SaO2 or SpO2 is the amount of oxygen that's combined with hemoglobin, so you have to check your hemoglobin level to make sure it's adequate. If it's not, you will not have an adequate SaO2. Normally, it's more than 95% on room air. You can also, I'll go back one. You can also do, check your base excess. And when you get your blood gases, it'll automatically come up there. Plus or minus 2 is the average. If it's greater than 2, you're alkaline. If it's less than 2, you're an acid. Your anion gap is what looks at your electrolytes. And this can identify the cause of acidosis if you don't have blood gases. It'll show a sodium minus your chloride plus your bicarb. The normal is 8 to 16 milliequivalents per liter. This will increase with diabetic ketoacidosis, alcoholic ketoacidosis, lactic acidosis, renal failure, rhabdomyolysis, and toxins like aspirin and methanol. A non-anion gap acidosis can occur with diarrhea, renal failure due to low bicarb and high chloride, and so you end up with hyperchloremic metabolic acidosis. Changes in your pulse ox are due to changes in your hemoglobin level, decreased perfusion, or the administration of a vascular dye. Sputum analysis on page 594. There's a box that tells you the procedure for collecting this. A bronchoscopy, you'll be NPO for 6 to 8 hours for that. A thoracentesis is removal of a large pleural effusion. You don't want to remove more than 1,500 milliliters because that puts your patient at risk of increased mortality, as it increases the risk of pulmonary edema due to an increase in negative pressure. If the patient starts coughing or complains of shortness of breath, stop what you're doing. A VQ scan, I skipped ahead. Pulmonary function test, there's a table on page 596 that talks about pulmonary function and the norms for that. Your ventilation perfusion lung scan, again, I said should have dots above each of those. This is the gold standard for pulmonary embolism. It identifies dead space, and the more it's increased, the more dead space that you have. Back to pulmonary function test. Your normal vital capacity is 10 to 15 milliliters per kilogram. Your negative inspiratory force or pressure should be a negative 20 to 25 centimeters of water. Your spontaneous tidal volume should be at least 500. And if you have all those things and the patient's respiratory rate is also less than 24, you can wean the patient off the ventilator. So those are things that come in handy when you're trying to decide about taking somebody off a ventilator. You also have to have a normal hematocrit. Your chest x-ray, there's a figure on page 598 that shows it. It identifies the bones in the chest, your mediastinum, your diaphragm, your pleural spaces, your lung tissue, if there are any wires, tubes, or IV lines there, any masses, consolidation or fluid. Chest x-ray comes in very handy. Your end-tidal CO2 monitor, or capnograph, identifies changes in dead space by establishing your PaCO2 levels. Possible causes of an increase in your end-tidal CO2 will be a decreased pulmonary blood flow, decreased cardiac output, and lung disease. It can also be used to identify endotracheal tube placement and pulmonary blood flow. It will increase with an increase in dead space. And your pulse ox, which is your SaO2 or your SpO2, and we've already talked about that. Pulmonary disorders. Acute respiratory failure is your PaO2 is less than 60, and or your PaCO2 is greater than 50 with a pH less than 7.35. There are two types. You have type 1, where you have a normal PaCO2 with a decrease in PaO2. This is called hypoxemic normal capnic respiratory failure. It's due to a VQ mismatch and intrapulmonary shunting, probably due to pulmonary embolism, atelectasis, or pneumonia. Type 2 is a decrease in your PaO2 with an increase in your PaCO2. This is due to alveolar hypoventilation. There's a table on page 604 for the causes, and another table on 606 and a figure on 605 for the signs and the symptoms. There's a concept map that puts all the pieces together on page 603. The more organs you have fail, the more mortality there is. So it can go, if it's just the lung, from 22% to where it involves more than one organ system to 75%. Some of the causes of acute respiratory failure can either be extrapulmonary, in other words, like the brain, the spinal cord, or the neuromuscular system, and will involve the thorax, pleura, and upper airways, or intrapulmonary, which will involve the lower airways, the alveoli, and the alveolar capillary membrane. Medical treatment, and it's in a box on page 608. You need to treat the underlying cause, always. And then to promote adequate gas exchange, you want to place them on PEEP, positive vent expiratory pressure, or CPAP, continuous positive airway pressure. You want to keep that SaO2 greater than 90%. If their pH is less than 7.25, you want to place them on assist control ventilation to control that. You want to correct the acidosis if the pH is less than 7.1. You will give bicarb. Nutritional support is really necessary as soon as possible because for people with respiratory problems, it takes an additional 700 calories just to breathe. And the enteral route is preferred. Now you can wait 24 hours if necessary, if they're malnourished, before you start it. Although why you would, I don't really know. And if they're well nourished, you could wait up to 72 hours. But again, why would you wait to make them malnourished before you start it? It doesn't make sense. So nutritional support is important, and you need to start it as soon as possible. If you're using a tube feeding, you want to use Pulmonary because it's low in carbohydrates, because carbohydrates break down to CO2 and water, and they don't need any more CO2. You want to prevent complications such as ischemic or anoxic encephalopathy, cardiac dysrhythmias, venous thromboembolism. To prevent the venous thromboembolism, it's really easy. Use some EPC cuffs. Get the doctor to order some low molecular weight heparin. Turn them to range of motion. And GI bleeding, another complication. Put them on H2 antagonists, PPIs, or cytoprotective agents for that. Some of the medications that are done, bronchodilators, your beta agonists, and your anticholinergics, aid in smooth muscle relaxation. Your neuromuscular blockade, analgesics and sedation decrease the work of breathing. Your steroids decrease inflammation and enhance your beta-2 agonists. Xanthine, bronchodilators are not recommended any longer because of your side effects that go along with that. The only instance where you would do that is if you'd had a patient long-term on a xanthine bronchodilator such as theophylline or Slowbid or one of those drugs, you probably would continue that as an IV infusion. And mucolytics and expectorants are no longer used at this time. Nursing diagnoses are on page 607, and your evidence-based practice is on page 608. Positioning is really important, and you need to know why you're doing what you're doing. Keep in mind that the right lung is larger because there are 3 lobes rather than 2, and therefore it's much more vascular. So if you have a VQ mismatch, you want to put the least affected side down so that you can ventilate and perfuse the other side better. If it's bilateral, you put the right side down because, as I've already said, it's larger and more vascular, and so we'll tolerate it better. Your alveolar hypoventilation, you want to sit them up to make it better. And as we'll talk with surgery, if they've had a pneumonectomy, you can put them on their operative side or sit them up, but you don't want to put the operative side up in the air. Your pulse ox, to keep an eye on the oxygenation. Remember, we want to keep that greater than 90%. Have them on rest to decrease their anxiety. Humidify the air. Make sure they take deep breaths. We really don't have them cough a whole lot because that promotes collapse of your small airways. But you do want them to take a deep breath in and hold it. And you want them to use incentive spirometry, which means they get 10 breaths per hour with that. You elevate the head of the bed 30 to 45 degrees. And you want to start patient education as soon as possible. And that is on page 608 in a box for you to look at there. Always increase your oxygenation with suctioning. And in fact, I have a slide just on suctioning. Acute lung injury is the new term for severe respiratory disease. It does incorporate ARDS, which is acute respiratory distress syndrome, the most severe type of acute lung injury. It is also called non-cardiac pulmonary edema with disruption of your alveolar capillary membrane. In order to determine whether or not somebody has this, they have to have had an acute onset. Their PaO2 has to equal their FiO2, which is usually less than 300 millimeters of mercury, and the normal should be greater than 256. They'll have bilateral infiltrates on the chest x-ray, and their pulmonary capillary wedge pressure or the pulmonary artery occlusive pressure, same thing, will be less than 18 millimeters of mercury. Risk factors can be direct or indirect, and they are in a box on page 609. If they're direct, they're things like aspiration, near drowning, pneumonia, oxygen toxicity, pulmonary contusion, toxic inhalation, transthoracic radiation. If they're indirect, it's things like sepsis, trauma, hypertransfusion, cardiopulmonary bypass, pancreatitis, embolism, DIC, and shock. Mortality for ARDS is between 30 and 50%. That has gone up. It had been 30 to 40, but in and of itself, it's just 30 to 50%. There are 3 phases. First is your exudative phase. This occurs within the first 72 hours. It occurs after the insult, and you'll have an increase in capillary permeability that causes protein to enter the interstitium. This will cause an increase in your pulmonary artery pressure and microemboli as the capillaries are damaged. Then you'll have an increase in hydrostatic pressure in the interstitium that pushes fluid into the alveoli, compressing the alveoli and the small airways. This is the pulmonary edema, and it's non-cardiogenic. There's not a problem with the heart at this time. You'll also have impaired surfactants, so you'll have alveolar capillary collapse in a patient who develops hypoxia. The symptoms are in a table on page 611. The second phase is your fibroproliferative phase. This occurs after 7 to 10 days. You'll have decreased surfactant production, so you'll have collapse of the alveoli. You'll have hypoxemia due to shunting and the VQ mismatch. You'll have an increase in airway resistance and a decreased lung compliance, which causes an increase in work of breathing due to atelectasis and compression of the airways, which will cause fatigue and hypoventilation. And so you end up with pulmonary hypertension due to that microemboli, the hypoxia, and the vasoconstriction. All those will cause an increase in dead space and an increase in right ventricular afterload. So this does decrease cardiac output. This phase can last up to and including a month. The resolution phase starts after that. Hopefully it'll start after 2 to 3 weeks. You'll have collagen deposits in the capillary alveolar membranes. You'll have pulmonary fibrosis, increased pulmonary pressures, and decreased oxygenation. And the recovery is directly related to the absence of multiple organ dysfunction syndrome and sepsis. If you don't have those, you recover a whole lot better. Symptoms, as I said, are on a table on page 611, but here they are kind of averaged. For the exudative phase, you're going to have tachycardia, restlessness, apprehension, use of your accessory muscles. For the fibroproliferative phase, you're going to have dyspnea, agitation, fatigue, crackles, and an increase of your accessory muscles, increased use. You're going to have a decrease in your PaO2 and your chest x-ray that shows whiteout. In the resolution phase, you're going to have worsening hypercarbia and hypoxia and end organ dysfunction, or you're going to get better. Your medical goal is to treat, of course, the underlying cause. Then you want to improve the gas exchange, and you do that by placing them on a ventilator to keep your PaO2 at 90% with less than 50% FiO2. Tidal volume is usually done at 6 milliliters per kilo to decrease the amount of barotrauma that might be there. Respiratory rate 20 to 30 per minute to decrease your PaCO2. But if necessary, they will allow that PaCO2 to increase 10 millimeters an hour until it reaches a max of 80 to 100 millimeters. They want to keep the pH between 7.2 or greater. And you want to administer bicarb if necessary. So if that pH drops to 7.1 or less, you'll give bicarb. To improve the oxygenation, you will use PEEP, positive end expiratory pressure, to increase compliance and decrease shunting. But keep in mind, PEEP also causes hypotension and a decrease in cardiac output, so your blood pressure may drop a little bit. And you want to prevent complications, so you're going to turn your patient, do range of motion, use EPC cuffs, make sure they're well hydrated, and talk to the doctor about Lovenox, or low molecular weight heparin therapy. PEEP stands for positive end expiratory pressure. Side effects, as we've already mentioned, are decrease in cardiac output. This is due to a decrease in your preload and in your venous return, due to an increase in your intrathoracic pressure, and an increase in alveolar rupture because of the pressure that's there. Usually PEEP is run around 10 to 15 centimeters of water. If it's too high, it will decrease pulmonary capillary blood flow, decrease surfactant production, and increase shunting. If it's too low, it will increase alveolar collapse. Your ventilator settings usually have a tidal volume of our norm, which is 10 to 15 milliliters per kilogram. That's our normal. But for these patients, it may be too high. So that's why they allow the permissive hypercapnia, which we've already talked about, keeping your tidal volume at 6 to 10 milliliters per kilogram to decrease trauma or pressure to those alveoli, and allowing your PaCO2 to increase to a max of 100 millimeters of mercury. You want to keep that pH at 7.2 or greater. Remember, you cannot allow that PaCO2 to rise if you have increased ICP, intracranial pressure, pulmonary hypertension, seizures, or cardiac failure. Pressure-controlled ventilation is used to decrease the volume trauma that can occur. Tidal volume varies from breath to breath, but problems occur as the lungs stiffen over time, and a decreased ability to ventilate will occur. It can cause severe hypercapnia as a result. The pressure is applied on inspiration. Inverse ratio ventilation increases inspiration time, decreases expiration time, which is not normal for us. So these patients have to be sedated. But it does maintain the mean airway pressure, so the alveoli stay open. It decreases the work of breathing, but it does have the disadvantage of causing auto-PEEP. As I mentioned, they need heavy sedation or neuromuscular blockade to keep the patient from fighting or bucking the ventilator. It can either be pressure-controlled or volume-controlled ventilation. High-frequency oscillatory ventilation uses constant airway pressure to promote alveolar recruitment without causing overdistension. This would be used if your patient remains hypoxic regardless of what you've been doing. This uses very low tidal volumes with very high rates. We're talking a respiratory rate of 300 to 3,000 breaths a minute. I have never seen anything like this, and so I don't even know if we do it in this area. But it is, according to the research, something that could be done. Last resort therapies. In order to decrease the damage to the lung tissue, they will use ECMO, which is extracorporeal gas exchange. This is like an artificial lung. It uses a membrane to filter the blood, similar to the heart-lung bypass, to remove CO2 and add oxygen. It causes a major risk of bleeding with all types, and there are 3 types we're going to talk about. ECCO2R is extracorporeal CO2 is removed. IVOX, IVOX, is intravascular oxygenation, and this implants a fiber oxygenator into the inferior vena cava. And then you also have exogenous surfactant that can be applied to the bronchial tree. The exogenous surfactant would be 3 to 15 milligrams per kilogram as a normal dose, to a maximum of 300 milligrams per kilo that goes into the endotracheal tube by aerosol or bronchoscopy. This works really well with neonates, but has been shown to have very minimal benefit with adults. Some investigational therapies are partial liquid ventilation of a perfluorocarbon. This decreases the surface tension of the alveoli, and it increases compliance of the lungs, the chest cavity. Remember, compliance is the ability of the lungs to expand. It doesn't talk about recoil, it talks only about expansion. And it increases solubility for oxygen and CO2, so it increases gas exchange. Inhaled nitric oxide, which is a very potent bronchodilator and pulmonary vasodilator, is done to improve ventilation and perfusion. This is administered by the ventilator at 2 to 20 parts per million. Side effects are platelet inhibition, increased left ventricular filling pressure due to decreased increased right ventricular stroke volume, rebound hypoxemia, and pulmonary hypertension. Neither one of these have been shown to decrease mortality at this time. I don't know if it has decreased the length of time, but they're still looking at it to see if there's a benefit here. Some drugs that are being tested are your steroids, your prostaglandin E1, your prostacyclin, your lisofylline, your ketoconazole, and your N-acetylcysteine are all being tested as possible therapies. So as the nurse, if we look at it by nursing diagnoses, we want to maintain tissue perfusion. So we want to keep that pulmonary capillary wedge pressure or occlusive pressure between 5 and 8. To do that, we will administer diuretics and decrease their fluids. We want to keep their cardiac output between 4 and 6. So to do this, we'll administer your vasoactive medications and your inotropic agents. And both of these interventions are done to decrease fluid leakage into the lungs. You want to block inflammatory mediators. So as a result, we may administer steroids or monoclonal antibodies, antioxidants, or platelet activating factor inhibitors. We need to make sure your patient has an adequate hemoglobin in order to transport appropriate oxygen. And they need a good cardiac output also. Your collaborative management you'll find in a box on page 613. Your nursing goals for ARDS and ALI are to optimize oxygenation and ventilation. So that's very similar to that of acute respiratory failure, so you need to see the interventions for acute respiratory failure. Prone positioning increases oxygen and perfusion to the dependent areas of the lung, which are affected more in acute respiratory distress syndrome. To get the best effect, it must be done early in the treatment, and it's recommended that they stay prone for 30 minutes or longer. It's effective if their oxygen will increase 10 millimeters within that time. And there's a picture of a prone patient in that position on page 665. Most of these patients are on, all of them are on the vent. Most of them also have multiple IVs. So the best time to do your prone positioning is at change of shifts. So before you start report, you put them in prone position, and then after report's all over, about half an hour later, you take them out of the prone position because you need lots of hands in order to do this. But it works really well. You want to provide comfort, emotional support, and again, prevent complications, and we have talked about that. So again, if you have questions, you give me a call, email me, see me in lab, something.